So our first speaker is a good friend and colleague of mine from the University of Michigan, Dr. Shanti Eswaran, who's an associate professor there and really an expert in functional GI and motility disorders, but more broadly, just gastroenterology in general. And she's going to give an overview of the gastrointestinal tract to hopefully put all the subsequent talks into some greater perspective.
And then we're going to go ahead and do the other two as well. So do you want to go ahead and introduce those?
Sure. Next, we're going to have Dr. John Pandolfino.
I'm sorry. Yeah, it's okay. Is it playing?
My name is Dr. Shanti Eswaran, and I'm here to talk to you about Gut Matters 101. Welcome to this exciting day today at the Norton Educational Series. And we're going to have a lot of really great content to talk about with you. But first, I thought it would be great to talk about general GI physiology and anatomy so we can understand what's going on during the rest of the speakers today. So when we talk about the GI tract or digestive system or gut, what we're really talking about is a series of organs. And our digestive system is made up of a series of organs that allows our bodies to absorb nutrients and water from the food we eat. And as food travels through the digestive system, it's broken down, sorted, and reprocessed before being circulated around the body to nourish and replace cells and supply all of the other very important organ systems in our bodies. And usually this series of organs is doing its job kind of under the radar and unbeknownst to us. But occasionally, however, as many of you know, and as we'll learn about more today, this isn't always the case. So think about it this way. You are anticipating a fresh baked apple pie coming out of the oven. And just the sight and the smell of it are really enough to make your gut kick into high gear. And so we'll discuss this whole process as food moves down and through the GI tract, starting from the top. So digestion actually starts in the mouth, where chewing and saliva breaks down food, so it's more easily processed by your body. It then is transferred from the mouth and throat into the esophagus, which is a muscular tube connecting the throat to the stomach. The esophagus contracts as it moves food from the mouth into the stomach, and this process is called peristalsis. So you're swallowing this bite of pie, the muscles in your mouth and throat propel it up to the upper esophagus, and then the muscles in the wall of esophagus create these synchronized waves, where above that morsel or bite of food, the muscles are contracting, but below that bite of food, the muscles are relaxing, allowing the food to pass through without resistance to the lower part of the esophagus. And when the lower part of the esophagus kind of senses or feels that bite of food there, there's a valve at the lower part of the esophagus called the lower esophageal sphincter, or LES. And this then allows the food to, the esophagus then relaxes, allowing the food to pass in to the stomach through the lower part of the esophagus. Most of the time, the stomach contents and acid in the stomach stay below the lower esophageal sphincter. And while some reflux of contents and acid are normal, gastroesophageal reflux can occur when too much acid or other stomach contents flow the wrong way, sometimes causing symptoms like regurgitation or heartburn. There are other symptoms or disorders related to common conditions of the esophagus. These include esophageal strictures, which is a partial blockage in the esophagus, which can lead to some swallowing difficulty. Also, Barrett's esophagus is a condition where there's abnormal cells at the lower part of the esophagus, possibly increasing your risk for esophageal cancer. And then finally, motility disorders can occur when peristalsis is disordered, sometimes causing esophageal pain or swallowing difficulties as well. So moving on from the esophagus to the stomach, after that bite of food moves from your esophagus to the stomach, that pie or a little bite of food is broken down further. And the stomach has very strong muscular walls. And in addition to storing your meal or holding that food, the stomach's job is to churn and mix the food into smaller and smaller pieces. The digestive glands in the stomach lining produce stomach acid and enzymes, which mix with the food to form a murky semi-fluid mass or paste called chyme. And here, the muscular walls of the stomach, along with the digestive enzymes, mix up the food, further breaking it down, and then waves of muscular contractions propel it through a valve called the pylorus or pyloric sphincter, which opens and closes, allowing the food to pass from your GI or from your stomach into the upper part of your small intestine or duodenum. This pylorus opens and closes and might release about 1/8 of an ounce or 4 milliliters of chyme at a time. The rest of it's held back for more mixing until it's small enough to pass through. There's really common stomach disorders that you may or may not have heard of. The first one that we'll talk about briefly is called peptic ulcer disease or ulcers. And this is generally caused by non-steroidal anti-inflammatory medications like ibuprofen or naproxen, but also a very common bacteria called H. pylori can cause stomach ulcers as well. Gastroparesis is a motility disorder of the stomach, which is caused by slow stomach emptying. Here, patients might have abdominal pain related to food, nausea, and vomiting. And then another common disorder is functional dyspepsia. And functional dyspepsia is a disorder where we can't exactly understand why patients have symptoms, but in this case, an upper scope may be normal, and blood tests and motility testing may be normal as well. So moving on from the stomach to the small intestine. The small intestine is kind of the workhorse of the GI tract. It's the longest portion of the GI tract, over 20 feet long. And here, the food continues to break down, enzymes released by the pancreas and bile released from the liver. It's made up of 3 segments: the duodenum, which is the most upper portion and the shortest portion of the small intestine, followed by the jejunum and ileum, which are really mainly responsible for the absorption of nutrients. As bile and pancreatic digestive juices mix with other juices secreted by the wall of the small intestine and stomach, all of these nutrients are then absorbed through the villi, which serve to increase the surface area of the small intestine, allowing for greater and greater nutrient absorption. And in the intestine, including the jejunum and the ileum, food is broken down into smaller molecules so that it's absorbed. The ileum is really mainly, the ileum is the lower and most final portion of the small intestine, again, responsible for breaking down and absorbing virtually all of the nutrients that are passing through the GI tract, save for plant-based fibers that can't be broken down all the way. Common disorders of the small bowel or small intestine that you may be familiar with include celiac disease, where the small intestinal villi or those finger-like projections are damaged or flattened related to inflammation triggered by gluten protein that's found in wheat and wheat products. Similarly, Crohn's disease can damage the villi, but in Crohn's disease, there's often seen these small ulcers that you see here that can again lead to damage to the villi and also decreased absorption and abdominal pain. Certainly GI infections like viral or bacterial gastroenteritis can cause disorders of the small intestine. Small intestinal bacterial overgrowth, or SIBO, is also in this category. And also irritable bowel syndrome can affect the small intestine and the colon as well, that we'll get into. In the upper section of your small intestine, or the duodenum, digestion continues as chyme from the stomach mixes with a variety of digestive juices from your pancreas, liver, and gallbladder. The pancreas is tucked just behind the stomach, and it produces digestive enzymes that help break down proteins, carbohydrates, and fat. The liver is responsible for many things, including producing bile, a solution that helps you digest fats. It also helps to filter the blood that's absorbed and filter the nutrients that's absorbed from the small intestine going to the liver, which then can pass throughout the body to nourish all of the other cells and organ systems that require the nutrients absorbed from the GI tract. The bile stores, the gallbladder stores the bile that the liver is making. If the bile is not necessarily needed at the time that the liver is producing it, the gallbladder can store it and save it for a time when it's needed, especially after a fatty meal. There's several disorders that are associated with some of this pancreaticobiliary system. The pancreas can be sometimes inflamed, which can lead to a pretty painful condition called pancreatitis. If the pancreas isn't able to make the enzymes that are needed by the GI tract, that can lead to some difficulty with absorption or malabsorption with pancreatic insufficiency. And then finally, pancreatic cancer can occur involving the pancreas as well. The liver is the most common disease of the liver is fatty liver disease, which can then sometimes lead to inflammation. Cirrhosis of the liver or scarring of the liver can be triggered by medications, infection, alcohol, and fatty liver disease as well. And the gallbladder may be affected by gallstones, which could cause intermittent abdominal pain, usually in that right upper quadrant of your belly. And then the gallbladder can also become infected, leading to fever and pain as well. As the residue passes from the small intestine into the colon, nearly all the water is absorbed. This 5 to 7 foot long muscular tube connects the small intestine to the rectum. And the real job of the colon is to absorb water and process this waste so that defecation can then be easy and convenient. The muscles in the wall of your colon separate this waste into small segments that are pushed through from your lower colon and into your rectum. And it's made up of 3 parts here. The ascending on the right part of your body, the transverse colon, which moves the stool, at this point it's called stool, from the right side to the left side across your abdomen, and then the descending or left colon and the sigmoid colon connecting to the rectum. Common colonic conditions, of course, include constipation and diarrhea, which may be actually normal from time to time, irritable bowel syndrome, ulcerative colitis, where there's inflammation in the walls of the colon, sometimes causing diarrhea and bloody diarrhea, and then colon polyps and cancer. Colon polyps are actually fairly common. About 20 to 30% of individuals have colon polyps on colonoscopy. And if they're not removed, they may go on to become colon cancer. We're almost done here, down to the rectum and anus. And the rectum is a 8-inch chamber that connects the colon to the anus. The rectum receives stool from the colon and sends signals to the brain that if there's stool to be evacuated, alerting the brain that this might need to happen in the near future. But if that's not possible, it can also relax and expand, holding stool until evacuation is convenient. As the rectal walls are stretched, they signal this need for a bowel movement. The anus is comprised of several muscles, the pelvic floor muscles that kind of hold everything intact, and then 2 anal sphincters, the internal sphincter and external anal sphincter, that can relax and contract as needed. And all of these muscles together work to control defecation. Their jobs are to detect rectal contents and can really sense whether they're liquid, gas, solid, and then they can control when stool should and shouldn't be excreted from your body. Common anal rectal disorders include anal fissures, which is a tear in the anal skin at the outside of the anus, hemorrhoids, engorgement of the blood vessels that are draining the anal rectal muscles, fecal incontinence, which can include both loss of control of gas as well as stool, pelvic floor dyssynergia. Pelvic floor dyssynergia is when the anal rectal muscles aren't coordinated in order to have a quote unquote normal bowel movement. And then finally, rectal prolapse is where the lining of the colon or the rectum can come through the anal canal, causing some discomfort and feeling of incomplete bowel movements or incomplete evacuation. So as we stated earlier, the vast majority of the time, your GI tract is working under the radar to perform this vast number of functions, digestion, absorption, all to nourish not just the GI tract, but all of the cells in your body. And most of the time, we're not even really aware of the fact that this is happening. When this doesn't happen, we may become symptomatic, and there can be a lot of reasons for this. This can include disorders of the gut-brain interaction. There can also be perturbations in the GI microbiome contributing as well. Finally, nutritional causes may be playing a role in the imbalance or balance of the GI tract and all of its functions. And some of this we're going to learn about later today. So thanks for your attention. I think that we have a great program for you today, and I'll be here throughout the day to take any of your questions if needed. See you soon.
Hello, my name is John Pandolfino. I'm a professor of medicine at the Feinberg School of Medicine, Northwestern University, and chief of the Division of Gastroenterology and Hepatology at Northwestern Medicine at Northwestern Memorial Hospital. Today, I'm going to be doing a talk on disorders of the throat and the esophagus and how we approach this. Now, esophageal symptoms, when you think about them, whether they're heartburn, which is a burning sensation in the chest, regurgitation, which is essentially bringing food up into your mouth, dysphagia, the sensation that food is not traveling through your esophagus, chest pain, or even getting a food impaction, your differential diagnosis in terms of what this could be is pretty vast. It could be reflux disease, GERD, gastroesophageal reflux disease. It could be eosinophilic esophagitis, which is an allergic reaction in the esophagus. It could be an obstruction from either a stricture or injury and inflammation. Hopefully not a tumor, but certainly could be that, although that is rare. It could be a motility disorder or a functional esophageal disorder, which may be related to either visceral hypersensitivity, sensing things at a physiologic level, or even just being hypervigilant to that particular symptom. Now, regardless of how patients present with these esophageal and throat conditions, all of our workups really lead to endoscopy or visualization of the area to rule out mechanical obstructions, injury from reflux, and allergic reactions, especially in the esophagus. Now, that being said, if we see a negative test where the endoscopy is negative, which does happen quite often, then these are the patients who may have a motility disorder or a functional disorder or non-erosive reflux disease. And this is the standard diagnostic algorithm that we use for most of these esophageal symptoms. And as you can see, I don't want you to go through this part, but really what I want you to see is after we get the history and physical exams, at that particular point, we will always lead this diagnostic approach to endoscopy, usually with biopsies or even laryngoscopy, looking in the throat with our ENT colleagues. And really, when I go through this, that is really the starting point of my workup. When patients come in, I typically will treat most patients with these kind of symptoms with a proton pump inhibitor, and I'll schedule them for endoscopy. And as I go down this list, this is what I'm looking for as I approach the patient, thinking about what could potentially go on in this particular patient. And then if there is the possibility of maybe some inflammation like esophagitis, a stricture, I will address those directly during the endoscopy. But as I mentioned, at least 50% of the time, the endoscopy is negative, and we have to move on to further evaluation with esophageal function testing. And then, of course, thinking about what the appropriate treatments are. Now, in terms of, as I mentioned, the idea is this is what esophagitis or a stricture would look like. You can see this inflammation sitting around the esophagus. You can see this narrowing here. This is what we would see typically with pretty severe reflux disease. And if I saw this, I would know what you have. I would treat you with an escalation of anti-reflux therapy. Now, if I saw this, this is what an allergic reaction, eosinophilic esophagitis, looks like in the esophagus. This is actually a piece of chicken that's stuck in the esophagus. And this is related to an eosinophilic. It's a specific allergic cell type that infiltrates the lining of the esophagus and creates a more stiff esophagus, so food gets caught. So once again, if I see this, I'll know exactly how to treat this with acid medicines, and then of course some anti-inflammatory agents that are typically topical steroids. And then sometimes I'll actually see these anatomical deformations like a hiatus hernia where the stomach is actually above the diaphragm. And then certainly I will think that maybe we need to treat this with a surgical remedy. But as I said before, many times these approaches show us that most people, or 50% of the time, these people will have a normal endoscopy. This is what a normal end of the esophagus looks like. This pearly white mucosa here, lining, is actually the esophagus side, and then this salmon color below here is the stomach. And this is a nice intact squamocolumnar junction, which is the end of the esophagus and beginning of the stomach. And you can see here on the retroflect view where I'm looking backwards, I can see this flap valve that is created in this particular patient. And that is the anti-reflux barrier. Once again, that same location as we see in this first image here. Now, if someone does have a negative endoscopy and they're complaining of regurgitation, chest pain, dysphagia, or food impaction, this is when we get a manometry. And really what this is this is a very fancy tool to measure pressure along the length of the esophagus. Now, these tracings was the old way we did it, and now we have this much more intuitive way to do this, which we call esophageal pressure topography with high-resolution manometry. And with this now, we're able to see anatomy along with the pressure patterns. And the pressure signals are on this hot-cold scale. So if there is a red color, it's high pressure. If there's a blue color, there's low pressure. And by taking those images and looking at distinct patterns, we can actually define and classify esophageal motility disorders. And this is really important because we will treat patients based on some of these patterns. For instance, if you have achalasia, and you'll see here type 1 achalasia, you will actually get a treatment that will rely on disrupting this lower esophageal sphincter so that we can open up that obstruction. Whereas if you have one of these disorders like jackhammer or spasm, type 3 achalasia and spasm, we may give you a smooth muscle relaxant, which will relax the wall of the esophagus so it's not contracting and spasming as much. Now, as I mentioned, there's a lot of fancy algorithms that we use, but when we actually go through a manometry, this is actually the flow process that we think through when we make one of these diagnoses. And as I talked about, some of these diagnoses are actually diagnoses where you have an obstruction at the end of the esophagus, and others are actually diagnoses where you actually have impaired propulsion, where the esophagus is not pushing the food and the liquid through the esophagus appropriately. Now, you don't have to really go through this, but this just gives you an idea of how we follow through the process of making these diagnoses. And then, of course, if we don't suspect motility and we're thinking that you have reflux disease, we'll actually put a little capsule here at the end of the esophagus, about 5 or 6 centimeters above that squamocolumnar junction where the stomach and esophagus meet. And we'll measure your acid by looking at the pH in your esophagus over 4 days, over 96 hours. And what we find is this is a very useful test for us to decide whether or not you actually have reflux or you don't have reflux. And with this particular test, we can actually direct therapy. So if you don't have any reflux, we stop your proton pump inhibitor or take you off acid suppressive medicines. And then we start to think about other things, like can this be a functional disorder? Can we try neuromodulators, cognitive behavioral therapy? Or we also make sure we're not missing a motility disorders. But certainly if you have 1 or more days, we stratify how aggressive we're going to be in terms of your acid suppression and your anti-reflux therapy, either increasing your acid dose or maybe even referring you for an endoscopic or surgical treatment for your reflux. Now, this is another more fancy tool that we use that uses a catheter we place down your nose, where we can actually measure air and liquid reflux. And in this example, this is actually the white color represents liquid refluxing up the esophagus. Now, this is a little bit more difficult in terms of for the patient because this requires a catheter down your nose. That other process was a capsule that was placed, and you don't have a wire or a capsule out of your nose, so a little bit more comfortable. But this is a much more accurate way to define people who are not getting better with reflux. So if you have reflux, and we know you have reflux, this is the test that we'll use to see why the medicines are not working. And we can look at all of these fancy parameters to see the reflux. We can look at air and the belching patterns. We can see whether there's rumination, where there's an effort, almost a subconscious effort to move stuff up from the stomach. A very difficult thing to diagnose sometimes, and sometimes you need these particular tests. This is a nice example of that high resolution manometry again. Here's the upper sphincter, the lower sphincter, and the purple color is liquid moving up into the oral pharynx, and there's regurgitation there. This is an example of how we can diagnose something like rumination, which is where people subconsciously, although it is voluntary, bring up fluid and food into the mouth from the stomach by raising the intra-abdominal pressure and pushing it up. And once again, many patients don't even realize that they're actually doing this because it's a learned behavior, and we can effectively treat this with diaphragmatic breathing. Now, also, many times we encounter patients who actually, we initially think have an esophageal problem, but the problem is really more relegated to the throat area. And one of the more common things that we see is globus sensation, which is a lump in the throat. And once again, I show this algorithm just like I did for the esophagus, because as you can see, right after we take a good history and do a physical exam, the next step is really doing the laryngoscopy and endoscopy. And really what you're trying to do here is you're trying to look and make sure you're not missing anything. Here is a little cancer that you might miss. And once again, most people with a lump in the throat don't have cancer, but we really want to be careful. And that's why it's important for us to send you to an ENT doctor for that laryngoscopy. And if that's negative, we will try to treat you for reflux. And if you don't respond, we typically, once again, do an endoscopy. Now, really, when all of these tests are negative, so say, for instance, we see a patient with these esophageal or throat symptoms, the endoscopy, laryngoscopy is negative, there's no evidence of reflux or a motor disorder, that's when we really start to think about a functional bowel disorder. And this is really where we start to think about how patients' esophageal sensitivity interacts with their hypervigilance, their levels of anxiety, and really how does that affect their symptom perception and then their quality of life. And this is really a very cyclical process. And what we find is that we can actually break that cycle and address those hypersensitivity and that anxiety, that visceral anxiety, sometimes with what we call neuromodulators. Now, none of these neuromodulators are FDA approved for this. They're actually off-label, but this is pretty much a very standard of care approach for various things like chest pain, refractory GERD, and globus. But probably what I'm using a little bit more in my practice is really a focus on behavioral approaches, really using hypnotherapy, cognitive behavioral therapy to really divert patients' attention away from the symptoms and help them self-manage their symptoms and live a better quality of life. And I think that this has been a very instrumental part of my clinical practice. So in conclusion, the functional esophageal disorders really require us to go through this very thoughtful process where we look for problems with endoscopy, direct visualization. When we don't see something on direct visualization, we start to think about, okay, is this a physiology problem with motility, or is this reflux? And if those are ruled out, that's when we start to recognize that visceral hypersensitivity, hypervigilance, and psychosocial stressors may be at play. And then we target our therapy towards these particular components. So with that, this is a very important slide because once again, it highlights the fact that this is a real problem focused on a real abnormality that can be addressed with neuromodulation and behavioral interventions. So thank you very much for your attention, and I hope this was educational.
Hello, I'm Jan Tack. I'm going to present an introduction on gastric motility disorders. I'm a gastroenterologist at University Hospitals in Leuven, Belgium. So the stomach is a complex organ. It has many functions: initial storage of the meal, then it starts digestion, releases it to the duodenum in a controlled way. It helps to defend against GI infections. It's involved in satiety and hunger signaling, and it helps absorption of vitamin D. And if we look at the physiology centered around meal ingestion, prior to the meal, the stomach is actually contracted. And during the meal, it relaxes to store the meal. We call this accommodation. And then the next phase is empty. Throughout meal intake and after the meal, there's a sensation, a perception, which should be favorable, positive. And also meal intake triggers gastric acid secretion and release of certain peptide hormones. And when the meal moves into the duodenum, gastric acid secretion alters, there's duodenal secretion, and different hormones are released. So all of this is complex and can go wrong to give rise to gastric symptoms and to a number of conditions. In the Rome 4 consensus, these are the main conditions associated with gastroduodenal functional disorders. And I will be mainly addressing functional dyspepsia. I will be addressing nausea, vomiting, and gastroparesis. So functional dyspepsia, this is a just published European consensus, is a condition characterized by postprandial fullness, early satiation, epigastric pain, and burning with a negative endoscopy. Often associated upper abdominal bloating, nausea, belching, and gastroparesis, also from the same European consensus, is a condition characterized by symptoms associated with delayed gastric emptying in the absence of mechanical obstructions, and the symptoms are nausea, vomiting, and early satiation and postprandial fullness. So let's go in a little bit deeper into the symptoms. Where are stomach or gastroduodenal symptoms felt? In this square, actually, between the umbilicus, the lower end of the sternum, and the mid-clavicular lines. And the symptoms that can be experienced are depicted here in pictograms: fullness after meals, early satiation, a tightening so the stomach doesn't open to store the meal, epigastric pain and epigastric burning, and there's often also upper abdominal bloating, a sense of gaseous distension. Heartburn is behind the chest bone, nausea is a kind of sinking feeling in the stomach, and belching, I think, is self-evident. So when patients present with these symptoms, we will usually do an endoscopy, and when that's negative, it's considered to be a functional or motility disorders, and then we can do additional tests. Why should we consider doing additional tests? Well, they may help to explain the symptoms, help to make specific diagnosis, determine the choice of treatment, and predict long-term outcome. Any test that does all four of these is a very useful, almost ideal test. I will be showing you some data on patient cohorts seen with upper GI symptoms and negative endoscopy. The prevalence of symptoms is shown as the yellow bars, expressing percentage of the population of patients who have them in a moderate to severe fashion. And the patient populations I will be addressing are overlapping dyspepsia and gastroparesis, two different groups who have some overlap. So the first test we can do is measure gastric emptying rate. And there's many techniques, but clinically, it's scintigraphy, breath tests, and smart pill that are the relevant ones, the ones that clinicians use. The oldest one and best established one is a scintigraphy. A meal is radio-labeled, it is ingested, and when the patient has ingested the meal and is behind a gamma camera, you can see the outline of the stomach with the radio-labeled meal in there. You draw a region of interest, and you look over time how the radioactivity disappears from the region of interest, and that allows you to calculate gastric emptying time. In the US, there is recommendations on how to do the test, which meal to use, but still I think there's a lot of heterogeneity, and in other parts of the world, this recommended uniform test has not been picked up. In Europe, and actually in our center, the breath test was developed, which uses a stable isotope labeled meal component. 13C is non-radioactive, and that substrate is degraded immediately when it empties from the stomach. It's degraded in the duodenum, digested in the liver, and appears in the breath as 13CO2, and you have an appearance and disappearance curve or a cumulative filling curve. And from these curves, you can actually use different mathematical models to link them to scintigraphy, and so it allows you to get the same type of information as you would get with scintigraphy. Very popular in the US, a little bit less in use in the rest of the world, is the smart pill, which measures pH, manometry, and temperature, and allows to quantify gastric emptying time, intestinal transit, colonic transit, and phasic motility on one manometry port. This is an example of a tracing. You see the drop in pH when the capsule falls into the stomach. You see phasic contractions here, and when it leaves the stomach, you have a higher pH. And further down the tracing, you can also identify a transition point between ileum and colon. And when the temperature suddenly changes from 37 degrees to surrounding temperature, it means the smart pill has left the body. That allows to measure colonic transit time. Actually, the driver of emptying are high amplitude gastric contractions, either phase 3 or isolated big contractions. And so if you look at the correlation between the smart pill determined gastric residence time, seen as a pH step up, or the phase 3 of the MMC after the meal, this is well correlated. So it doesn't measure emptying directly, it measures an indirect phenomenon, the permission again of gastric phase 3 after the stomach has emptied completely. And can you explain symptoms with it? Well, first of all, if you look at 100 patients, around 30% of them with upper GI symptoms and negative endoscopy will have delayed gastric emptying. And in our hands, in yellow, compared to those with normal emptying in white, they have more fullness, more nausea, and more vomiting. And a couple of series in the literature, especially when patient groups of more than 300 were studied, found similar correlations, mainly with fullness, nausea, and vomiting. So there is a link with the symptom pattern. This is also often used in diabetes, and in diabetics, there's also a correlation between the retention of solids at 100 minutes on scintigraphy and the symptom score. It is a significant, not very strong correlation, but again, if you look at the symptom pattern, 2 of the studies actually show an association with bloating, fullness, but the sample size is smaller in diabetics. And then does it determine treatment? Well, the idea is that delayed gastric emptying through several pathophysiological changes induces gastroparesis symptoms, and that prokinetic drug treatment can reverse that, and that will be addressed in the treatment section of gastric motility disorders. The second one, which I will address shorter, is the gastric electrical rhythm. Contractions in the stomach rise from around this zone and travel down towards the pylorus to empty gastric content. And we now know that these are driven by interstitial cells of Cajal, a special rhythm-generating cell network and a pacemaker region here. But now there's a new evolution with a body surface gastric mapping device developed in New Zealand by Greg O'Grady and colleagues, which allows to map in detail the origin and propagation of slow waves. And I think this idea of measuring the rhythm-generating symptom is again up for a renewal and a revival. Gastric sensitivity is another one. You know, after the meal, there is perception which should be pleasant, and also during the emptying phase, there is perception, and we can study this by blowing up a balloon in the stomach and looking at the threshold to induce discomfort or pain. And compared to control or organic causes of dyspepsia, let's say a peptic ulcer, patients with functional dyspepsia, so with negative endoscopy, are abnormally sensitive. Here in this study, more than 60% were abnormally sensitive. If we put all the studies together, it's 40% that are abnormally sensitive to gastric distension. And in our hands, in yellow, hypersensitivity to gastric distension compared to the normal sensitivity in white is associated with much more pain, much more belching, and unexplained weight loss. So we call this visceral hypersensitivity. It's a modality that is not measured in clinical practice, but it is a driver of symptom severity in many conditions, including FD, including gastroparesis, and in the lower GI tract as well, in IBS, for instance. The last factor is gastric accommodation. This is the first phase of meal ingestion. You ingest a meal, the stomach makes space for it. And we already have indirect evidence that this is abnormal in functional dyspepsia. In health, the radio-labeled scintigraphy meal is immediately after ingestion, mainly in the proximal stomach, whereas in FD, with normal emptying here, it is in the distal stomach, suggesting that this part does not relax well. The gold standard is the barostat, a balloon device swallowed, lodged into the proximal stomach, inflated with a fixed pressure that allows to measure volume shifts in the proximal stomach. This is the preprandial. After a small liquid nutrient meal, this is a postprandial proximal stomach volume, and you can quantify this. And if you do this type of measurement or alternatives, imaging, for instance, like scintigraphy or with SPECT imaging, you actually find that 44% of patients with upper GI symptoms and negative endoscopy have abnormal accommodation. And in our hands, this is associated in yellow with early satiation and unexplained weight loss. So also this one is associated with the symptom pattern and is present in a subset of the patients. Now, the barostat balloon is invasive. It's a big thing to swallow. It is unpleasant. Nobody uses it in clinical practice. So people have looked for alternatives for the barostat measured accommodation. A simple one is the nutrient drinking test. A liquid nutrient composition drink is dripped into 2 beakers. The patient is asked to drink and keep up drinking by alternating the beakers as they fill and scoring satiation every 5 minutes. And if you do that on one day and you look at the end point, the calories or volume ingested when they stop, this is well correlated to a barostat test on another day. So this is a very simple gastric accommodation testing procedure that you can do in patients. The other one has been manometry. This is a standard esophageal manometry catheter now moved into the stomach. And if you move into the stomach, this is what you get. This is the lower esophageal sphincter with swallows. The single line is a single swallow, esophageal peristalsis. This is the proximal stomach. This is the antrum, phasic contractions close to the pylorus. And here ingestion of a liquid meal is started, and soon after, the pressure in the proximal stomach drops. It becomes blue, lower pressure, because blue is low pressure, green intermediate, red high. So you get a low pressure that gradually recovers. Upon meal ingestion also, the phasic contractions in the antrum are suppressed. And so if you plot this, you get a drop in intragastric pressure followed by a gradual recovery. And this is associated with the rise in satiation score. And if you do this in controls in blue versus functional dyspepsia patients, the drop in pressure is suppressed in functional dyspepsia. The meal volume tolerance is smaller in functional dyspepsia. The rise in satiation with meal ingestion is faster in functional dyspepsia. And the size of the pressure drop is correlated to the tolerated meal volume. So showing that this pressure drop is an indirect measure of gastric accommodation. So how does this work in clinical practice? People are seen with symptoms, fullness, satiation, pain, burning. This is the dyspeptic symptom pattern, or nausea, vomiting. You do the endoscopy, and it is negative to think of a motility disorder. Here you do the endoscopy, perhaps some other investigations as well for nausea, vomiting. If the endoscopy is negative, here you have a functional dyspepsia diagnosis. Here, with negative findings, you have chronic nausea and vomiting disorder. And then if you do the emptying test, it can be normal or delayed. In dyspepsia, if it's normal or delayed, you have dyspepsia with normal or delayed emptying. In nausea, vomiting dominated people, you have, when it's delayed, gastroparesis, when it's normal, chronic nausea and vomiting disorder with normal emptying. So that's what I wanted to tell about gastric symptoms and gastric testing, and I hope you enjoyed this brief presentation. Thank you for your attention.
Hello and welcome back. We hope you enjoyed our very first session of the Norton Educational Series 30th Anniversary Edition. Before we continue, we wanted to just talk a little bit about what we just heard from these 3 wonderful speakers. And first, let's talk a little about some of the definitions, some of the words that you may not have understood. know that we had several of the speakers talk about the gastric duodenum. Dr. Che, can you tell us what exactly is the gastric duodenum?
Yeah, so gastric refers to the stomach, and duodenum refers to the first section of the small intestine. It turns out that there are terminology to describe the first part, the middle part, and the farthest part of the small intestine. The duodenum is the first part, the second part is the jejunum, and the third part is the ileum. So when we talk about gastroduodenum, we're talking about the stomach and the first part of the small intestine.
Fantastic. So that makes a little bit more sense. Thank you so much. Another term we heard quite a bit was visceral hypersensitivity. John, can you explain to us a little bit about what that is? I know it's complex,
Yeah.
but if you can give us sort of a high level view, that would be fantastic.
Yeah, I certainly mentioned it a little bit in my talk as we discussed some of these disorders. And really, what it is it's an ability for the gut or the bowel to sense things at a lower level. So, for instance, the way I describe it to people is, if I blew a balloon up in my esophagus, I may not feel it until a certain volume, but if I blew that balloon up in someone else's esophagus, they might feel it at a very low volume, where even if it's just mildly stretching the wall, that is sent as a signal as pain. And we find that, and we can see that people have different reactions and different triggers for reaction. So even though there might be normal function, that the bolus is going through the lumen, that volume is distending it, it may not cause symptoms in one person, but because it stretches and triggers in another, they feel that perception of pain. And that can be very, very problematic in terms of quality of life, and really annoying in many ways, because you can feel that over and over. And that is something that we can modulate by effectively treating some nerves to not feel it, not sense it, not get triggered. And that's where you see us using a lot of these techniques like neuromodulators, medicines that affect the triggering of the nerves, and then even some of the behavioral instances like hypnosis, kind of shifting your attention away from those hypersensitive areas.
Fantastic. Thank you so much. So we want to answer some of the chat questions that we had from the audience this morning. And we had two questions that came in with Dr. Eswaran's talk from Michigan about the digestive system. And the questions were, what is diverticulitis and what is gastroenteritis? So Bill, can you maybe talk a little bit about those and what those might look like?
Sure, absolutely. And let's start with gastroenteritis. So first thing to point out is gastroenteritis is different than gastritis. I know that they sound a lot alike, but they're not the same. So gastritis is inflammation in the stomach. Gastroenteritis refers to an infection that occurs in the gastrointestinal tract and typically leads to symptoms like nausea, vomiting, diarrhea. So in layman's terms, things like food poisoning or traveler's diarrhea would represent gastroenteritis. And remember that gastroenteritis can be from bacteria, viruses, or even parasites. So any infectious organism that gets into the GI tract and causes inflammation and that leads to the development of these symptoms, nausea, vomiting, pain, and or diarrhea, can cause gastroenteritis. Now, diverticulitis is oftentimes used interchangeably to refer to inflammation in a diverticulum, that is an outpouching in the lining of usually of the colon, but it can occur anywhere in the GI tract, versus just where we talk about diverticulosis, where we're referring just to those outpouchings without the inflammation. So when people talk about diverticulitis, we're talking about a circumstance where that diverticulum has gotten inflamed, infected, and leads to severe abdominal pain, as well as fever, and is related to that inflammation and infection in a diverticulum.
Okay. And I think we're going to hear a little bit more about that later on in some of our talks in the next session. But thank you for that quick overview. That was great. And so, John, we did have a question on your talk in the esophageal, and so wonderful to have you here after giving such a great talk about the esophagus. And so, one of our viewers wanted to know, at what point or what when they go in to see a specialist and they're having issues in their upper GI tract, what are some of the things that you really need to hear from them? So the symptoms that they're experiencing, or the things that you need as a gastroenterologist to know, to be able to make a really good, accurate diagnosis.
Yeah, so I think that certainly we have these symptoms called warning signs. And one of the first things that I'll ask people, particularly because that could mean that they have either a blockage, there's a stricture, or something that I can take care of, like scarring that's blocking flow. So I'll ask people, are you having trouble swallowing? Do you feel like things are getting caught? Is there pain when you're swallowing? Do you have any evidence that you're having any bleeding, which could be black tarry stools or blood in your stools, or maybe the fact that you might have anemia? Are you losing weight but not trying to lose weight? Those are some of the global kind of warning signs that we look for. But the other things that I actually look for and want to know from patients is how is this affecting your life? Is this affecting your sleep? Sleep is a big deal for us when we deal with throat problems and esophageal problems, because if you're having trouble with your throat and your esophagus, you could be microaspirating. So we're very concerned about your sleep. Obviously, also, we talk about your weight, even outside of a warning symptom. In fact, we track your weight to see how well you're doing. The other thing that I'll probably do a lot in my clinic, especially when people are coming with esophageal problems, I'll actually watch people eat or swallow. I'll give them a glass of water, watch them swallow, see how it's working, look at the throat, look to make sure that the anatomy is changing from an airway to a foodway. How easy is it for them to swallow? So I'll watch them kind of eat. I think those are really the important signs and symptoms that we're looking for in the clinic.
Fantastic. Thank you. That's very helpful. So another question we had during your talk was, you mentioned jackhammer, and that's, I think it's pretty rare. Is that rare?
It's very rare. And in fact, I think that most of the time when it gets used, it's probably not a significant motility abnormality like many people think. Really what jackhammer is it's really a repetitive, really strong contraction trying to force the food bolus or liquid bolus into the stomach. And it can be caused by an obstruction that might have been missed, like a little hernia, a stricture. We see it a lot of times in people who've had operations in the GI tract, but every now and then it can be just related to the muscle. And we're still not exactly sure what causes these kind of really strong contractions that give you jackhammer, but sometimes we can treat that effectively with medicines that relax the smooth muscle.
So if someone has jackhammer, what symptoms would they present with? So if I was to, is there pain, or is there what?
There can be pain, and there can be dysphagia, which means trouble swallowing or getting food and eating and getting it from the mouth into the stomach. But we see a lot of these patients who actually present with heartburn and regurgitation too. And that actually gives us kind of a pause to treat it as a primary motor abnormality if they have symptoms of heartburn with that. Because as I mentioned, sometimes we can see this with reflux and a hernia.
Okay. So, and I know that in your talk, you talked about doing the manometry to be able to see how those muscles work. And so that would really give us a good idea. And thank you for that was a wonderful presentation with all the different options there. Of what could possibly go wrong, which was a lot, which again underscores the need to go see your physician if you're having any symptoms that persist, like Lynn had mentioned this morning. So let's move on to Jan Tack's presentation. So he asked about, he mentioned something about body mapping. So what is body mapping?
So Jan Tack, as many know, is a world expert on motility, and in particular the upper GI tract motility. And he obviously showed nice examples of very sophisticated technologies. And one of those technologies was body mapping. And although that's not clinically available right now in the United States, there are centers using it in research capacities. It's really a very high resolution ability to look at the electrical activity across the upper GI tract. And we know that there's different signals of electrical activity that they can actually characterize by looking at this body mapping. And we think that this may give us a non-invasive test to really look at how the muscles and the nerves are acting in the upper GI tract.
That's technology. It's really an amazing thing in medicine right now. So one of the things that we've heard this morning that we will be hearing throughout the next couple days is we talk about medications that are FDA approved. So Bill, can you talk a little bit about what that means to be FDA approved? And I think we hear that a lot today as well, right? In other things outside of our gastroenterologists, but.
Well, Cecile, there's a complicated process by which a drug receives FDA approval in the United States. And of course, FDA approval is critically important for patients to look out for because it's really a sign that a medication or a device or a test has gone through a rigorous process of testing to be sure that it's of adequate quality and that it does what people claim that it's going to do. So realize that for a drug, there are phase 1, phase 2, and phase 3 trials. And the ones really to focus on are the phase 2 and phase 3 trials where the clinical efficacy, the right dose, and the safety are all identified. And these trials oftentimes include hundreds, if not thousands of patients. So as I said, it's a really rigorous process to achieve FDA approval.
And so in a normal timeline for a medication, let's say someone wanted to do something for GERD, for example, what does that timeline look like? How long would that sort of take a company?
It varies a lot by the compound and the indication, but probably it's more like a 3 to 5 year process. So it takes quite a long time for a drug to initially begin testing and then to get through all those phases of development and then finally achieve FDA approval. Just to give you an idea, like all the background research that occurs leads to something called a new drug application or NDA. Once the NDA is filed, it's at the absolute shortest a year and usually about 2 years to get through the regulatory process to be FDA approved. So just that from the NDA is at least a year and more realistically, probably 2 years.
Helps to understand why there's so few drugs on the market and why we're constantly doing research to get more. So just real quick, I know we have to move to our next session soon, but we did get a question about how the pancreas impacts the GI system. So who can answer that really quick?
I mean, I can take that a little bit. So, I mean, obviously the pancreas is really important for digestion. It does serve a function in modifying your sugars too, which can affect motility. But I think in terms of how we like to think about it, it's really a digestive organ. And if you lose the pancreatic function, you're not able to break down food appropriately. And then there are malabsorption where now you're not able to absorb these nutrients. And then, of course, the bacteria like to interact with some of these foods a little bit too much. And this is Bill's world too, where people get, a lot of gases that are accumulating and they get bloating and diarrhea. And it's extremely important. It's one of the organs that kind of gets out of the GI tract in a way. We kind of forget it in our motility world. But certainly it's an adjunct organ that's extremely important. And if it's not working, people can have horrible pain, bad, quality of life with bowel movements, and then, obviously malabsorption, not getting the appropriate nutrients and vitamins, which can have devastating effects on the rest of the body.
Right. Absolutely. So it is an organ that I know is small but very important. So thank you for that question from the audience.